Pharmaco-invasive strategy for STEMI elevation. Of course, primary PCI is the standard of care, and we know, or we are the interventional cardiologists understand that cardiovascular disease or in myocardial infarction is still high in mortality, and the pathophysiology is like this: the STEMI that totally occluded in epicardial artery. There is the rupture in type 1 acute myocardial infarction due to the thrombosis. So it should be revascularized. It should be reperfusion within 2 hours. Within 2 hours for primary PCI or whatever equipment that you have. If you have fibrinolytic, you can open the vessel with pharmacology by fibrinolysis, even tenecteplase, alteplase, or streptokinase. But the problem in STEMI is the unmet of reperfusion strategy. More than sometimes, even in very equipped hospital with a cath lab, even more than 10 cath lab, sometimes the strategy of more than 2 hours. So I want to share the experience about the how to manage STEMI in our country. We know about the STEMI. I don't too much talk about the STEMI. And the problem is not all center are capable of performing primary PCI in timely PCI within 2 hours. So if your cath lab more than 10 cath lab, but all cath lab equipped, even the electrophysiology study, PCI, complex rotablation, and PCI is not achieved within 2 hours. So you should try pharmaco-invasive strategy. So primary PCI, we should achieve 90-minute door-to-balloon time, or in first medical contact to reperfusion is within 120 minutes for timely PCI. So can our patient arrive within 2 hours for timely PCI? The real world perspective, even in US, this data from US, many American underserved for primary PCI. More than quarter STEMI cases are identified at hospital, the lack of PCI capabilities. Most adult intensive care units are not equipped to provide post-cardiovascular care. Alarming, about 66% of in the US do not meet the recommended time of standard of care of STEMI. If patient came to the hospital, in non-PCI capable hospital, they try to reperfuse with fibrinolytic strategy. They give tenecteplase or alteplase or streptokinase first, and after that, in 2 hours, they send to the cath lab for primary or for rescue or invasive strategy. Guideline for major cardiology group, PCI in Europe to 24 hours after fibrinolytics, and for American Heart Association 324. The challenge of timely primary PCI is compounded by the need of specialist facilities and skilled team, which are unavailable in low and middle income country. So in current situation in Indonesia still have Delhi is very high. Then Malaysia, maybe in Philippines and Vietnam, our Delhi is almost 22% for the highest share of total disease burden in Southeast Asia. It is the problem, and many island, almost 17 island in Indonesia, and the number of cardiologists is very low. Access, quality, timely medical care remains significant. In 18 provinces, 94% of households are located more than 5 kilometers from primary care facility or hospital with limited access to transportations. So it is the big island, and more than 60% of cath lab in Java Island. Indonesia more than 17,000 island, and there is the small island there, the Java Island, and most cath lab more than 70% in Java Island. There is Borneo Island, Sumatra Island, Papua Island. It's not many cath lab there. So the cath lab is not distributed well. So how to treat patient with STEMI, and the guideline and the ACC guidelines tell us should be within 2 hours if the situation like this with the island country. So we have a guideline also in our country, pharmaco-invasive strategy for STEMI in Indonesian asset guideline. The guideline is not for for citizens live in the cities, live in Jakarta, Bandung, or maybe the major city, but also in the island, in the remote area. It's very important. They should serve with a standard STEMI care for our citizens, our people in Indonesia. When to perform an invasive strategy after fibrinolysis, it is the challenge. We try to, in our guideline, during 24 hours, they should take the invasive strategy, even rescue PCI or invasive strategy for timely PCI within 24 hours in the cath lab. So the primary PCI, of course, performing in symptom more than 12 hours. And if you have any doubt, STEMI or not, there's LBBB or RBBB, you should go to the cath lab for primary PCI. And early PCI also, if fibrinolytic therapy is successful and early invasive strategy is recommended. So it is the invasive strategy after fibrinolysis. So it is our guideline. And if fibrinolytic is unsuccessful, we should go to the cath lab for rescue PCI within 24 hours. From our registry, from almost 8,000 patients from more than 8 hospitals, in ACS, there is almost 50% of ACS patients in Indonesia. And most of them reperfuse. 65% already give revascularization. And 45% they give primary PCI. But they performing primary PCI within 3 hours, only 21%. They have cath lab, they have interventional cardiologists, but they perform primary PCI within 3 hours, only 21%. I don't know in your center. Your center may be okay, but your country, we talk this about the country. So maybe some hospital in different hospital will equip well-trained cardiologists there. You can reach within 2 hours. But in other hospital, I think you cannot reach because not well equipped, maybe limited in interventional cardiologists. Lesson from Indonesia, 21% only in golden time, and more than 75% is more in timely PCI. And we know that we understand timely PCI will give good mortality. Then if you performing PCI in late PCI for STEMI, our registry, the transfer time is 165 with ischemic time of 405. So it means that even your cath lab is equipped well, and even you have trained cardiologists, interventional cardiologists, you will unmit the ischemic time until maybe more than 90 minutes. In our registry, 405 minutes to performing the PCI. So the pharmaco-invasive strategy is the potential alternative overcoming system delay in STEMI patient in Indonesia. So we're starting the program, initiative from government, Fast STEMI, standard for pharmaco-invasive strategy, tata laksana STEMI in Indonesian words. Diagnosis TMI in the hospital, can admit to the hospital and give, not hospital, but in primary care. In the primary care, in the remote area, they give if the patient admit with the STEMI, the doctor in primary care will take the ECG and send the ECG with telemedicine and give fibrinolytic after supervised by cardiologist in supervised hospital. So the hospital will supervise the primary care to give the fibrinolytic. So it is with the combined standard of care in hospital and telemedicine. So it is the teleconsultation from the physician in primary care. They take the ECG and send to the center, and the center put the conclusion, it is STEMI, go fit the next place. So we equip the primary care with the ECG, we equip primary care with the fibrillation, the defibrillator device, and we equip the primary care with this teleconsultation, and there is a spoke and hub system. This spoke and hub system from primary care to hospital, not hospital to hospital, but from primary care to hospital. The primary care take a ECG, send to the hub, and hub will respond within 30 minutes to give advice, to give a recommendation for, it is STEMI, anterior, inferior, and give recommendation for fibrinolysis. So you see the 17,000 island Indonesian country will be served with the standard of care of STEMI 34 province hospital. So we make the spoke and hub system. So this with fibrinolytic. So government provide with the regulation. It is the regulation for Ministry of Health, and the government putting the tenecte place in every fibrinolytic strategy in primary care. So the tenecte place based on the body weight. If a body weight less than 60, we give 30 milligrams. In body weight is more than less than 90, 80 to 90, we give 45 milligram tenecteplase. Not alteplase, but tenecteplase. Why we give tenecteplase, not alteplase or streptokinase? Because tenecteplase is only single bolus. Very easy for physician, for general physician to give fibrinolysis in primary care, and government equip all the primary care center in the country, in the island, with these drugs and some device. So it is the experience. I give a case, male, 60 years old, with acute semi-anterior, 6-hour onset, but all cath lab are occupied. We have 10 cath lab. I'm working in the National Heart Center in Jakarta. In Harapan Kita Hospital, we have 10 cath lab. All cath lab equipped and estimated more than 2 hours. So of course, in the emergency, we bolusly tenecteplase with fibrinolytic for this anterior STEMI. And after that, within 24 hours, the successful fibrinolytic, the fibrinolytic is success, but of course we see the vessel still lesion there. There is a multivessel disease that the previous speaker talked about the multivessel disease, and we open the culprit. Not complete PCI because regarding the insurance, regarding our national coverage, only one, and staging within 3 months. More than 3 months. If you open the vessel within 3 months, the government not cover. So if you put more than 3 months, the government will cover to open the other to staging PCI. This is the regulation of our country. So the first we open the culprit vessel first, and after that the patient okay, and this is timely PCI within 24 hours or early PCI 24 hours after 10K. And case 2, there are 53 years in for posterior pre-fibrinolysis television in T23 FF. And after fibrinolysis, there is no unsuccessful for fibrinolysis. This is because no resolution as elevation. Still there. There's elevation, the symptoms still there, and routine rescue PCI within 24 hours. So we extended the timely PCI. In primary PCI, timely PCI is 2 hours. So with TNK, we give extended for 24 hours. You can give the reperfusion within 24 hours. So give chance to patients or the facilities or the trainees or cardiologists preparing for PCI within 24 hours. So routine rescue PCI already done. Even in very equipped, well-equipped hospital and many cardiologists. Our cardiologists, we have 60 cardiologists in Jakarta in my hospital, and there is 25 interventional cardiologists there, but still there is not meet the timely PCI for STEMI. So my conclusion, the primary PCI is the gold standard for STEMI reperfusion, but limited access and geographic disparity often delay treatment. Pharmaco-invasive strategy still important, followed by PCI within 24 hours over particle device-based alternative in region without immediate PCI capability like Indonesia, and even if you can reach or meet the timely PCI within 2 hours. Fast STEMI program is implementing pharmaco-invasive strategy to address delay in STEMI care in Indonesia. Thank you.